There we go. All right, so with this, I'm just going to start, and Morgan can jump in when she gets on. So with this CVS, what is Tessa Coaza? Oh, hi.
Hey guys.
I wasn't sure who Tessa was. Or
That's
Teresa.
my mom, Teresa.
Teresa, sorry.
I had to use her computer because we're at the new house and I don't have Wi-Fi.
Oh,
So
no.
she like has a hotspot. Oh my
Oh,
God,
nice.
Miriam, look at that little outfit back there.
I know, I saw it too.
Does the same thing. That's gonna be you, Morgan, in a couple months.
It's so cute.
But girl clothes, right?
Yes.
Unless you want to dress them in drag, that's all right.
Hey, anything free, just send it my way, boy or girl.
Oh, let me tell you, that is the best. Like when you get bags of clothes from people that like hand you down.
Exactly. And you know, they're gonna just grow out of it. So like,
Oh my God, yeah.
or puke on it or poop on it.
Yep.
We're both.
Yeah, I feel like I buy him new clothes like every freaking 2 months, like a whole new wardrobe.
Alrighty, so I designed this course to really prepare you to be able to formulate exam reports. So when you get out into the clinical setting, especially when you start your fall and spring semester clinical rotations, I want you to be able to, complete an exam and then sit down and interpret, what you saw on the exam and be able to formulate your preliminary reports for the radiologist, in an attempt to prepare you to be, an entry-level sonographer and feel comfortable doing these things. So I was going to start today with our cerebrovascular reports, our carotid Doppler reports, because carotid Dopplers are one of the more popular exams that you're going to be doing in the vascular lab. So when any order comes in, the first thing you always have to do when you get your requisition or order is to check the indication, confirm the indication, make sure that the exam has a proper indication. Part of that being doctors don't necessarily know what they're ordering, so they can potentially order an incorrect exam. And the other part of that too is without a proper indication, hospitals will actually not get paid out for these procedures and the exams that we perform. So depending on who's interpreting them, if it's a vascular surgeon, they'll get very angry because they're spending their time dictating studies that they're not even getting paid for. So for cerebrovascular, flex. See that? Yeah, we're good. All right. So indications. You guys tell me, start throwing out some indications. Why do we do a cerebrovascular scan?
Shortness of breath.
Because no.
Oh, wait, I keep saying that.
You keep saying that. No.
I'm getting it wrong on the registry for sure.
Please do not.
Fainting.
Fainting, yes.
Fainting.
Oh my God.
Also be called syncope.
Yeah.
Sometimes you'll see it syncope and collapse, where they actually fall down.
They have like paralysis.
Sure, yeah. So any sort of paralysis. So that could be like facial paralysis, extremity paralysis, numbness, any sort of paralysis. Numbness, / weakness.
I like vision loss or something,
Sure,
or
yeah.
blurred vision, double vision.
Any vision disturbances? Double vision, diplopia, amaurosis fugax, all our stroke symptoms. So any sort of vision disturbances. Vertigo. Anything else you can think of? I know for in my hospital we had pre-op for cabbage, coronary artery bypass graft surgery. So that was an indication that we would do a carotid study. Because patients that have coronary artery disease will oftentimes have carotid artery disease. So the heart surgeons want to make sure that their carotid arteries are clear before going to surgery, because it makes the surgery much more risky. They have a higher incidence of having embolic stroke during surgery if they have significant carotid artery disease. And they may also elect to go in and do an endarterectomy at the same time that they're doing the coronary bypass surgery. So they might get a 2-for-1 deal. Another indication could potentially be post-op endarterectomy. So you can have history of carotid disease. So in those cases, you're doing a follow-up exam. So you want to see how the disease is progressing, if it's progressing, if it's getting worse. And typically, carotid disease doesn't get better, but you can slow down, the rate of disease, by controlling blood pressure, controlling cholesterol, controlling your diabetes, giving up smoking, exercising, doing all the good stuff.
So once they have like stenosis in the carotids, there's nothing they can do for them to like get rid of it.
Not really to break it up. I mean, because that plaque, it'll start forming, as like homogeneous soft plaque, and then it'll progress into more heterogeneous and start becoming more calcified. So once it really gets calcified, it really gets stuck in there, If the occlusion is due to like a fresh embolism, like say they had a thrombus in the heart that dislodged and went, got stuck in the carotids, then they could potentially do like, your TPN or your thrombolysis medications to try and break it up. But actual like, atherosclerotic plaque, like they're really, aside from like, doing an endarterectomy, there really isn't a way to really remove it through the use of medication. Like I remember I had this one patient, this one guy who knew he had carotid artery disease and like significant, like I think his velocity was like 400, 500 or something like that, and he was telling me, he's like, yeah, I've been like, trying to treat this with garlic, taking a lot of garlic. I'm like, yeah, no, you might want to consult with your doctor again, but he believed garlic was going to help him with that. Let's see other indications. So we have things for paralysis, weakness, vision disturbances, fainting, dizziness, syncope, collapse, vertigo. That's pretty much like, let's see, any signs or symptoms or even history. patient has a history of CVA, cerebral vascular accident, or TIA, would be another indication. So if we suspect a stroke or a TIA, then we could potentially be doing a carotid study. Or if they have a known history of a CVA or TIA. So make sure we got our proper indication for our order. Then we move on to doing our test. So with our cerebrovascular duplex exams, we have to remember that when assessing the carotids, a normal study is going to be an exam with no plaque. So you can't call a carotid exam normal if there's even just the smallest little bit amount of plaque. So a normal exam is no plaque at all, completely clean, nothing. So 1 to 49. Stenosis. So 1% plaque or 1% narrowing, degree of narrowing, diameter reduction. This is a 1 to 49% the diameter reduction. Or a 1 to 49% stenosis. We have to remember our peak systolic velocity is going to be less than 125 centimeters per second. And diastolic velocities going to be less than 40. So when you see a little bit of plaque and you measure your velocities, they should be below these thresholds, these 125 and 40 for your end diastolic velocities. You could potentially, if they're a young, healthy patient, have velocities over 125. So when we get to our reporting, I'll explain how you potentially write that up. You know, if you do see velocities that are over this threshold, but your visual plaque estimate. So this is your visual plaque estimate. Visual plaque estimate. So the next criteria that we go to is our 50 to 69% stenosis or diameter reduction. You know, with our 50 to 69% stenosis, you're going to have your peak systolic velocity 25 to 230. And diastolic velocity is going to be 40 to 100. And then your high grade stenosis is your 70 to 99%. That you have your peak systolic velocity greater than 230 centimeters per second. And your end diastolic velocity greater than 100. So you're not even going to be thinking twice about these numbers. They're going to become so ingrained in your head that you're just, as you're going along, you're like, all right, that's 50 to 69. That's greater than 70. You know, it's less than 50. So now that we've know our velocities, we perform our carotid duplex scan. We're familiar with how to describe the plaque in terms of its heterogeneity, like is it homogeneous, is it heterogeneous, does it appear ulcerative? We can then move on to understanding also what our waveforms should look like, because that also plays a factor into determining how we're going to write up our reports. So I put onto D2L some pictures that I found pretty helpful when looking at some of the waveforms. Screen share here. So, too fast. So here we have our normal CCA waveform. So this is again our combination between our ICA and ECA. So you get a pretty deep dicrotic notch here. ECA, we have a very fast upstroke and a very fast downstroke. I usually can determine my ECAs by seeing this little portion that dips below the baseline. A lot of ECAs will have that. And that becomes an important factor when you have stenosis within the ECA and you wind up with elevated end diastolic velocities and elevated, peak systolic velocities. And it can almost look like an ICA because those velocities are elevated and you have a high diastolic component. But I will still look for this deep dicrotic notch with an ECA and the potential of dropping below the baseline momentarily. That shows me that it's higher resistance. So this was a good picture showing, like what it looks like when we Doppler in the bulb and or if we're doing the proximal ICA and we're too close to that bulb, we would get some of those funky waveforms. So this is an example of a waveform actually in the bulb, where you get that mixing and swirling. Like, I know a lot of you in the lab be like, is this normal? Does this look normal? I'm like, just move a little further down, down the ICA and ECA, and then you should return to, what we perceive to be a more normal waveform. So, and this is a good example of a proximal ICA. And then as we move more into the mid ICA, we get into our more traditional, what we perceive to be look like a normal ICA waveform. So this is closer to the bulb. We still get a little bit of that influence of that mixing of the bulb. And then as we move away from the bulb, mid and distal, you can see as we're moving distal, more and more diastolic flow component. It becomes more laminar. And a normal vertebral artery waveform should look similar to your mid ICA waveform. So when we recognize normal, we also have to be able to recognize abnormal as well. So you look at this first waveform over here. This is going to be our post-stenotic tardus parvis waveform. So post-stenotic tardus parvis waveform. Keep saying that to yourself over and over. Post-stenotic tardus parvis waveform. So post-stenotic, this is going to be after stenosis. This is your typical tardus parvis waveform. Delayed upstroke, dampened waveform with diastolic flow. So this is a waveform that was taken in the common carotid artery, distal to a right innominate artery stenosis on the right side. So if this patient has stenosis in the right innominate and we're seeing a tardus parvis waveform here, they could potentially also have a right vertebral steal. So again, this is now common carotid artery distal to a proximal CCA stenosis. So this is our post-stenotic tardus parvis waveform, post-stenosis. So now this is a common carotid artery again, with now an ICA occlusion on that same side. So now we have an occlusion upstream. So that blood flow going up the CCA is now meeting up with that plaque that's higher upstream, or that occlusion upstream, and it's creating a lot of resistance within that artery, a lot of pressure. So we have a high resistant waveform with no diastolic flow component. So again, so this is now an internal carotid artery distal to a CCA stenosis. So again, our post-stenotic tardus parvus waveform. So this is an example of a waveform for an internal carotid artery with a less than 50% stenosis. So we wind up with some spectral broadening, but it doesn't look too bad. Our velocities are also within our normal threshold, so less than 125, and diastolics less than 40. This one I didn't agree with the picture actually. The velocities they're showing are like 250. So that would actually be a 70 to 99% stenosis. But if you want to compare, what they're calling greater than 70, you see velocities that are extremely elevated. It looks very turbulent. You get a lot of filling in the spectral window, a very high diastolic component to this one as well. So this for sure, is a greater than 70% stenosis, no question about it. I would probably classify this as well as a greater than 70% stenosis based on those peak systolic velocities. I mean, the end diastolic velocities, they're elevated almost to that 100 threshold, but that's kind of borderline. So I would, maybe this would be like right around 70, but because of those peak systolic velocities over 250, I would have to put it in that other criteria. This would probably be a good example where you could probably depend on your ratio as well as maybe like the deciding factor as to whether it's in this 50 to 69 or greater than 70. This would be a waveform from our string sign. So you can obviously see the significant plaque within the ICA. So even though your velocities are low, you can't call this, normal based on what you're seeing. So you have to use your eyes and not solely go on velocities. With our internal carotid artery with distal ICA stenosis. So this is an ICA that has an occlusion upstream. So this is going to be our thumping, our systolic thumping. So we get a very dampened waveform, no diastolic flow. And this is a good picture of an external carotid artery stenosis. So with our ECAs, we don't have an actual grading criteria to determine degree of stenosis. In our report, if we see elevated velocities in this ECA, we'll just write them up as elevated velocities demonstrated within, right external carotid artery. And it'll be on our report, what our peak systolic and end diastolic velocities are. So this is a waveform for the external carotid artery with reverse flow due to a CCA occlusion. So we have a blockage in our common carotid artery, which is preventing blood flow from getting to the ICA and to the ECA. So that side of the brain with the occlusion wants flow. So it's going to steal it from the external carotid artery. So we wind up with retrograde flow. And it's now low resistance because it's become internalized because it's now going into the internal carotid artery and up to the brain. So this is a good example of that internalization of the external carotid artery with retrograde flow. And similar to the ECA, we will document elevated velocities within the vertebral arteries if we encounter a stenotic lesion. But we also do not have specific grading criteria for degree of diameter reduction or degree of stenosis. So this is your vertebral pre-steal. So this is that crouching bunny sign or bunny sign. So this is an abnormal looking vertebral waveform. As that steal progresses or that stenotic lesion, that proximal stenotic lesion progresses in either the subclavian or on the right side, potentially the innominate. As it gets worse, it transitions into a partial steal where we have a systolic flow reversal and a return to antegrade flow during diastole. And if it progresses further, it becomes a complete steal where we have a fully retrograde waveform below the baseline. That's more peripheral. So this was just an example of, a carotid report. So every report's going to include your indication for exam. Oh, there, I forgot that one. An audible bruit. I knew I was forgetting one. So yeah, another indication could potentially be an audible bruit. If the physician hears a bruit, you can add that to your list of indications. So in this report, they described the plaque. So they have B-mode imaging demonstrated no plaque formation in the common carotid artery. Peak systolic velocity was 100 centimeters per second. So this is a kind of a general report. My labs, it would be a little more specific. We'd break down each segment of the CCA. But they also described the plaque that they encountered. So the heterogeneous plaque was noted in the proximal internal carotid artery with an elevated peak systolic velocity of 350 centimeters per second and an end diastolic velocity of 150 and an ICA-CCA ratio of 3.5. So based on those velocities, that would fall into that criteria of 70 to 99% stenosis. And then you also will include, your external carotid artery velocity, as well as whether or not the vertebral artery was antegrade or retrograde. Most of your reports, would typically be broken down, into right and left. Have your PCA, prox, mid, distal, PCA, ICA, prox. You'll typically have your peak systolic velocity and end diastolic velocity. So you'll fill out usually a worksheet in each lab. So you'll be like 100 over 20, 10, 25, 10, 25. ECA, you can have like 130 or 10. So you'll go through, you'll fill out your worksheet, with your peak systolic and end diastolic velocities for the right and left. When you're reporting vertebral, typically they'll only ask you, antegrade or retrograde. So you'll fill out your numbers. You'll write on your worksheet, whether vertebral is antegrade or retrograde. And then after you fill out your worksheet and your numbers, you'll then write your preliminary impression. So that's when you'll take your opportunity to describe the plaque. So then you write, sonographer, preliminary impression. This is where you're gonna be writing, the main portions of your report under that preliminary impression. So the first thing you want to do is identify areas of ICA stenosis with degree of diameter reduction. So the real purpose of us doing these carotid duplex exams is to really ultimately assess that internal carotid artery. I mean, that's the main thing that the physicians really care about, is identifying the areas of ICA stenosis. So where along that ICA is it stenotic? And what is the degree of diameter reduction? Is it a 1 to 49%, 50 to 69, or greater than 70 to 99? So identify areas of ICA stenosis with degree of diameter reduction. So that's where I'm going to use those criteria. Then we're going to describe plaque seen in carotid arteries. When we're describing the plaque, is it homogeneous, heterogeneous, calcified, does it look ulcerative, is it ulcerated? Does it look hemorrhagic? So those are all terms that you can use to describe the plaque seen in the carotid arteries. So when you're describing your plaque, you're describing the plaque that you see anywhere. So you can say, diffuse calcified plaque noted at the mid and distal common carotid arteries. Heterogeneous plaque noted in the proximal right internal carotid artery. Say diffuse calcified plaque seen throughout carotid artery system. If you see it everywhere, like, from start to finish, there's calcified plaque just going all the way up. As long as you get the general terms down, you can always ask a more senior technologist to help you, like, how would I really describe this, or how would they describe it? So you can always lean on other people to help you, when you're first starting out formulating reports. As long as you're familiar, with the general terms that you're going to use when you're describing the plaque that you see in the arteries. So in your preliminary report, you're identifying the areas of ICA stenosis with degree of diameter reduction. So, it's either normal, no plaque, 1 to 49, 50 to 69, or greater than 70, or 70 to 99%, depending on the lab, how they want you to describe it. You're describing the plaque seen in the carotid arteries as, either homogeneous, heterogeneous, calcified, ulcerated, hemorrhagic. Under your preliminary impression, you'll also, number 3, mention ECA ECA or vertebrals. Demonstrate elevated velocities. Preliminary report is where you're going to mention, that, all right, this patient has a stenosis in the ECA by using that line, like, right, ECA demonstrates elevated velocities. That's basically all you have to put in your report. Right, CCA demonstrates elevated velocities. Because we're not actually physically grading these stenosis, but we're mentioning it in our preliminary impression, like, hey, we saw that there's really high velocities in that external iliac artery. In this preliminary report, we're also going to mention results. So you're going to have a line in your preliminary impression, let's say, right and left vertebrals demonstrate antegrade flow, or, right vertebral demonstrates retrograde flow, and left vertebral that demonstrates antegrade flow. So you're going to mention flow direction of vertebrals. The last thing that you may include in your report could be waveform characteristics. So with waveform characteristics, we'll do our things as a post-stenotic, targus, Harvest, pre-stenotic, high resistant, I could say maybe post-occlusive, be another way to describe a waveform as a post-occlusive waveform. If you keep all these things in mind when you're formulating, your preliminary impressions, you're really impressed when you get to your first job, that you're able to write up your own reports and understand them and interpret them. All right, we're good. So I'm going to talk about arterial. Duplex. So peripheral arterial duplex, this is going to be either our upper extremity arterial duplex or our lower extremity arterial duplex. So if we're doing an upper extremity exam, a UE, it's going to begin with our subclavian artery. And subclavian artery, we do a proximal, mid, and distal segment. And remember, proximal is going to be more medial, mid, distal, working our way out. The next artery we image is our axillary artery. And we do our brachial artery. Brachial, we also have a prox, mid, and distal. And from brachial, we do our radial and ulnar. Our brachial splits into radial and ulnar. And with radial and ulnar, we also have our prox, mid, and distal segments. With the lower extremity, arterial duplex exam. Depending on your lab, I always started with the external iliac artery. Some places may just start with the common femoral artery, but external iliac artery, then you would do a common femoral artery. Common femoral artery bifurcates or splits, and we have our profunda, which can also be called the deep femoral artery. So we just do one picture, the proximal segment of that. And we do our SFA, our superficial femoral artery, going down the thigh at prox, mid, distal. Then we have our popliteal artery. And then we branch into the calf arteries. So in the calf, we have our ATA, anterior tibial artery, which we do a prox, mid, distal. Posterior tibial artery, prox, mid, distal. Peroneal artery, again, which has a prox, mid, distal. The last thing we do is a DPA, or dorsalis pedis artery. Dorsalis pedis. So out of all those lower extremity artery waveforms, really you want to make sure that you're getting blood flow down to the foot with your dorsalis pedis, as well as your distal PTA. So those both will show that you're getting perfusion to the foot. And you also want to assess as well, making sure that there's no inflow obstructions, that could potentially be affecting flow down the leg. I often find a lot of occlusions in the SFA, between the prox and mid segments, and wind up with recanalization further down, so into that distal SFA. But those are the basic arteries that you do. So with the peripheral arterial duplex exams, they can be very time consuming because it's actually a lot of images, because we're doing a 2D, a color picture, as well as our spectral Doppler waveforms. So each segment is at least 3 images, if not more. And then if you encounter any disease or stenosis, you're always adding on more pictures, because now you have to Doppler through that stenotic lesion before, in the stenosis, and after. All right, so with peripheral arterial duplex exams, probably the most important thing that you want to look for while you're doing the exam is look for changes in phasicity. What I mean by that, changes in phasicity, is if I'm coming down the leg and I have a normal triphasic waveform, which was our normal arterial waveform for a peripheral artery, and all of a sudden that waveform becomes monophasic, something had to have caused that waveform to become monophasic. So I now have to go back up that artery, up that leg, and try and find that stenotic lesions that changed phasicity. So changes in phasicity are going to be your red flag waving that, hey, something's going on here. There's a stenotic lesion somewhere in this artery that's causing this change in phasicity. So I'm just gonna pull up a couple diagrams that I uploaded that show phasicity well, so you can get a good understanding of what normal triphasic versus biphasic versus monophasic. This was a general chart, or a couple charts that I found. So this first one shows your normal triphasic arterial waveform, where you have your systolic component, and then a flow reversal during late diastole where it drops below the baseline, and then a progression of forward flow in late diastole. So these are your three phases. So one phase during systole, second phase below the baseline during diastole, and then during late diastole, return to forward flow. So that's a normal triphasic waveform. So this would be seen in your normal healthy peripheral arteries. As disease progresses, we then transition into what's called a biphasic waveform. So biphasic waveform here, we have our systolic component and then diastole below the baseline, but it never returns back above that baseline, forming that third phase. So we remain below the baseline during diastole. And then as the disease progresses and gets worse, we then transition into a monophasic waveform. So this is continuous forward flow during both systole and diastole. I mean, we have changes in velocity, during systole, of course, we have faster velocity, diastole less, but it's one flow direction, one phase. So monophasic, continuous forward flow. So this was another chart that I uploaded, just showing some examples of different types of flow. So antegrade versus retrograde. So just the terms, antegrade is the normal flow direction. Retrograde would be opposite to what the normal flow direction should be. So don't concern yourself with above or below the baseline. Just know what the normal flow direction should be. And then you describe it antegrade or retrograde based on what the normal flow direction should be. This is an example of bidirectional flow. So this would be in a pseudoaneurysm. We'd see something like this in the neck of the pseudoaneurysm. Absent signal. So then these show what they call multiphasic. So this are your triphasic and biphasic waveforms. And then examples of monophasic waveforms. So we could see they're all just above the baseline. And then this breaks down resistivity, like whether it's high resistant, intermediate, or low resistant waveforms. So we have our high resistant triphasic waveform, another high resistant waveform with no diastolic flow. And this could be considered more intermediate, where we do have some diastolic flow component, but it's very low compared to our peak systolic velocity. And then more of a low resistant waveform with a prolonged downstroke and continuous forward flow throughout diastole.
And
Yeah,
so that top one, like in the middle, no, go more down.
this one,
That, yeah. So no, the red one,
the red one, yeah.
is that considered monophasic or biphasic? Because it has like two little humps.
Yeah, so I found, I was actually looking into this. I found a couple articles. Some labs would call this biphasic because if it touches that zero baseline, they consider that biphasic because like you essentially the blood flow came to a stop. So I would look if it touches that zero baseline and then continues, I would consider that as biphasic.
Okay.
If it stays above that baseline and never touches that zero, then it would be monophasic.
Okay.
So that was one of the grading criteria that I saw. So like more often than not, you'll get it just for these peripheral arteries, I would have the peak systolic above and then below the baseline is going to be your diastolic component. So I'll have like systole and then I'll get diastolic flow below the baseline and then systole again. That would be a little tricky to describe. So that's why they some labs adopted this principle as multiphasic versus just monophasic, because there was some discrepancy as to like, what is really biphasic versus monophasic. And
Yeah. I saw a waveform like that when we did PVR SLP, and to me it looked like it was biphasic, but Nicole said it was monophasic, so that's why I was like a little confused.
okay. Yeah, I mean, I guess if it doesn't touch that that baseline and stays a little bit above it, then it could still be considered monophasic. So then these are our low resistant waveforms. So these would be our, post-stenotic tardus parvis waveform, dampened, low resistant. And then with low resistant waveforms, we tend to lose that end systolic notch or that dicrotic notch. This was a chart that showed, peripheral arteries. So this is a peripheral artery with less than 50% stenosis or diameter reduction. So I get a little bit of spectral broadening, but still maintains a little bit of that triphasicity. This is a 50 to 74% stenosis. So now we're having increased velocities. And then there's a ratio when we're doing peripheral arterial exams. So I'm explaining that in a minute. So that ratio becomes critical when we're determining diameter of stenosis. So with this 50 to 74%, we see spectral filling, that spectral window looks more turbulent. This would be, again, now a monophasic waveform. So we know that there's some sort of stenotic lesion that's causing that. This would be a high-grade stenosis where we have velocities over 400. And then again, our tardus parvis waveform, our post-stenotic tardus parvis waveform in a peripheral artery. And so this would be distal to stenosis. And then distal to an occlusion where we get recanalization, we wind up with severely reduced systolic velocities. So here they're measuring 20. This looks like it's less than 20. Again, these are tardus parvis waveforms, our post-stenotic tardus parvis waveforms. And then examples of peripheral arteries proximal to occlusions. So we have very, very high resistant, just a systolic component to it. So pseudoaneurysm. This is an example of what we could potentially see if the patient has an AV fistula. So this is a very turbulent flow that is also very low resistant. So again, so we're looking for that change in phasicity. You know, if we go from triphasic to biphasic, there could potentially be a stenotic lesion that's causing that. If we go from, particularly if we go from triphasic to a monophasic waveform, we know that that's probably a pretty significant stenotic lesion somewhere along the pathway that we now have to locate and document. So when we're grading diameter of stenosis, we use a velocity ratio. So this velocity ratio is similar to what we use for our carotid arteries, where we're taking that proximal ICA over the distal CCA. So this ratio, we do the same thing. So we're looking for velocity increases between two segments. So we do distal segment peak systolic velocity over proximal segment. Peak systolic velocity. So I'm using an example of we'll say this is lower extremity, so a leg, lower extremity. So blood flow in the lower extremities is going in this direction down the leg. So if we use our ratio, we're going to take the velocity that we get, you know, within our stenosis. So this is going to be our distal segment. So say this is 400. And the velocity that we get in the proximal segment before the stenosis, you know, say it's going to be 200. We'll plug those into our ratio, you know, 400, 200. So distal segment, peak systolic velocity over proximal segment, peak systolic velocity, we get a ratio of 2. So 2 is your magic number. So if you get a doubling of velocity within 2 segments in your peripheral arteries, that's going to indicate a degree of stenosis of greater than 50%. So 2 equals a greater than 50% stenosis. Greater than 50% stenosis. Some labs may just have you graded as a greater than 50% stenosis or a 50 to 99% stenosis. They may not break it down further. One of the vascular labs that I worked at, if the ratio was greater than 4.0, so we'll say greater than 2 is equal to or greater than 50% stenosis. If the ratio was greater than 4, they said this equaled a stenosis greater than 75%. So depending on where you work, they may not have you grade it, break it down in that criteria. They may just say a greater than 50% stenosis if you have a ratio over 2. So even if your ratio is 4 or 5 or whatever, they may just have you in your preliminary report say that it's a greater than 50% stenosis or 50 to 99% stenosis. Some labs, if you get your ratio over 4, they'll feel confident with you saying the stenosis is, 75 to 99. That's how we do our velocity ratio when we're doing our peripheral duplex exams. So it's that proximal distal segment over the proximal segment. So the distal segment is going to be your fastest velocity. So that's going to be, within your stenotic lesion. And then you compare it to your velocities proximal to that stenosis. All right, so this is an example of a peripheral duplex exam. So again, we have, I forgot to mention, let's talk about indications too. So indications for our peripheral vascular exams. So indication for this particular exam was extremity claudication. So indications. Sure. So our indications for our peripheral arterial duplex exams, again, claudication, pain, in general, patients having pain in the legs, other indications could be absent, diminished pulses. So if the doctor is trying to feel for pulses in the foot or pulses in the arm and they don't feel them, they could potentially order an arterial duplex exam at absent or diminished pulses. Cyanosis. That's discoloration. That's either blue / purple. That's purplish or blue discoloration. Ulcers, wounds. Those are typically going to be non-healing ulcers and wounds. Uh, Location, rest pain, absent pain, cyanosis, ulcers, wounds. Can also do follow-up exams. These are patients with stents. And grafts. As well as patients with known PAD, peripheral arterial disease. All right, so then again, this is an example of a peripheral duplex exam for the legs. So you'll mention your peak systolic velocities and you'll describe the waveform as either being triphasic, biphasic, monophasic, or we can use our terms, our post-stenotic turbulence. So in this one, we see a significant increase between segments. We have 80 in the proximal SFA, mid SFA, you have 400. So that's a greater than 4-to-1 increase. So that's a highly stenotic lesion. After that stenosis, we now have a monophasic waveform. So say I had missed this stenotic lesion in the leg, and I had a biphasic waveform. I went from triphasic to biphasic to then monophasic. I'm like, all right, something's up here, like I didn't know it was a big increase in velocities necessarily. Say I missed this lesion, I would now go back and try and figure out, all right, why did I go from biphasic now to monophasic? So these monophasic waveforms, you have typically they're going to be post-stenotic or within that highly stenotic lesion. So again, we see now a drop in velocities. So same thing in this leg. We went from triphasic, then all of a sudden, say we missed this lesion and we get to the popliteal, say we were too high up in the distal femoral artery and we still saw maybe a biphasic waveform or still a triphasic waveform. And we missed this lesion and we're now in the popliteal, all of a sudden it's monophasic. You have to go back up and try and find that lesion. What caused that change in phasicity. So always have that in the back of your mind. All right, I got a change in phasicity. What's causing it? Also, typically with our peripheral duplex exam, labs will want you to do an ankle brachial index. The ankle brachial index also helps give the physicians and doctors a good indication of how much perfusion is getting down to the foot. If there is presence of collaterals, that is helping it, as well as verifying, what your numbers are up here, if they're kind of jiving, like I'm finding a stenotic lesion here, and these are the waveforms of velocities I'm getting, lower down. does it match up with what we're getting, you know, with our PVR or ABI? So impressions they're not too bad in terms of our peripheral arterial exams. So basically you're just, you know, describing the segment and the degree of stenosis. I noticed some labs will describe the plaque as well. Typically it's going to be calcified plaque. You don't typically often find soft plaque within the arteries unless it's more of an embolic event that's caused that plaque. So it's typically calcified atherosclerotic plaque that you're going to encounter. Some labs may ask you to, you know, include patient history or risk factors into your report. So it's good to know, you know, what the patient's risk factors are they're pretty much the same across all arterial exams, whether it's carotid, peripheral arterial duplex, or, you know, your PVR exams. So your basic risk factors, you know, these are patients that have diabetes, hypertension. Those are your two main large risk factors. Patients who smoke, high cholesterol, obesity, patients with renal disease. So kidney disease can cause calcification in the arteries, specifically the peripheral arteries. So know your risk factors. Make sure you know your indications. You have proper indications for your exams. And then be able to look at your waveforms and read your waveforms, you know, and just be familiar with your velocities. And the last one is going to be your ABI and PVR exam. So with your PVR SLP, then they're not too difficult to interpret either. Once you get used to being able to look at the waveforms and decipher them. That's the good thing about vascular. It's all about numbers. So the numbers are what the numbers are, you know. PVR, self-gain. Waveforms. So we describe them as normal. Let me know if this is how Riddle does it. I would do it as normal, mildly stenotic, stenotic, severely stenotic, and occlusive. Like, how do they describe it at Riddle when they're doing their PVRs?
I don't think I've seen them write a report yet. That's what I was gonna do when I go back.
Okay.
I don't know about Miriam, but I mean, I've done PVRs. I haven't seen them write the report.
Okay.
Yeah, same.
Severely stenotic. So these are the 5 terms that I use when I'm writing up a PVR report, when I'm describing the waveforms. So you'll do your PVR SLP exams, your pulse volume recording portion of that. You'll get your waveforms at each segment or each level. So our normal waveform, draw a line out. Our normal waveform is going to have a fast upstroke. It's going to have a pretty sharp peak. You'll wind up with your dichrotic notch. when we move to a more mildly stenotic waveform, so with this one, we start losing that dichrotic notch. So begin to lose and lose dichrotic notch. We start getting some rounding of the peak. So the peak becomes rounded. And we also wind up with some widening of that arterial waveform. So we get widening. Widen waveform. If we move to a, what I classify as a stenotic lesion. So that's kind of like the waveforms that kind of look like those triangles. So now we have, you know, complete loss of that dichrotic notch. Make these a little more rounded. So, you know, we have rounded peaks. We typically lose a diastolic component to it, so. When I want to describe a waveform as severely stenotic, I call this kind of just like the rolling hills. So it's very low amplitude. Again, also, I forgot to mention stenotic. We also have reduced amplitude, reduced amplitude. And then our occlusive waveform, you know, it's just going to be kind of a regular, you know, it's not even going to be anything that we can discern as arterial. So it's can either be just a flat line across or just kind of a very choppy waveform, you know, where we can't actually pick up any sort of arterial signal. So that would be your occlusive waveform. Maybe just, you know, straight line across, completely flat. Typically not just completely flat, you know, just patients move a little bit, but you know, there's nothing that we can definitely say, you know, there's an arterial waveform in there. So that's what you describe as occlusive. So it's really not that bad. Normal, mildly stenotic. Stenotic is kind of like your little triangles. Severely stenotic, it's like the small little rolling hills, you know. And then occlusive. So when you're describing your waveforms. So this becomes important in patients, you know, that are diabetic, that have the medial calcinosis where the vessels are non-compressible and our pressures, you know, are we're not able to report an ABI because the vessels are non-compressible. We really depend upon our waveform characteristics to determine, you know, severity of disease. Sexy legs. So when we're doing our PVR exam, so we know that we're looking for pressure gradients or drops in pressure greater than 30 millimeters of mercury between segments, both vertically and horizontally. So looking for pressure gradients millimeters of mercury or greater. Segments both horizontal and vertical. So what I mean by both horizontal and vertical, we're looking for differences in pressure between two segments vertically as well as horizontally at the same level. So if I get, 100 here and 80 on this side, there, that there's an issue with the artery on that side because of that difference in pressure, both horizontal. I know some of our textbooks will say look for a gradient between 20 and 30 millimeters of mercury. But for me, that's kind of borderline. If the difference is 30 or greater, then you can be 100% sure that there's disease within that segment. So for me, 20 to 30 is kind of borderline. But again, you also have to, go by with what your lab says. I know the registry uses 30 millimeters of mercury. So if I was just to plug in some numbers here, I don't know, let's say 150, 10, go 100, 90, 80. Oh, we don't get a pressure there. Sorry. So we look at our diagram. We see a pressure gradient between these two segments of a drop of 40. So we'll know that the disease has to be at the level of this cuff or above. So the disease is at level cuff with lower pressure or above. So knowing that rule, when we're doing our preliminary reports, we can then describe the disease and break it down into different segments. So this is another part of your preliminary report. If you're able to, get these pressures and determine disease segments. If bilateral high thigh the ankle index. Oh, no, sorry, not high thigh to ankle. What am I doing? High thigh to brachial. Jeez. High thigh to brachial. So if the bilateral high thigh to brachial index is less than 0.9, then disease is aortoiliac. What's that saying? If say we get, I don't know, we'll just make 80, 85, advise, 70, 60, 50, 75, 65. And brachial pressure. If we plug that 80 into our high thigh to brachial index, we'll get a pressure measurement or a ratio of less than 0.9 that indicates that the disease can either be in the iliac or the aorta. If we see it bilaterally, so we have pressures low on both high thighs, less than that 0.9. The disease has to be either in both iliacs or aortoiliac, could potentially be the aorta that's just affected. I'm just gonna kind of put over here the different terms we use. We use aortoiliac, aortoiliac disease, iliac disease, so if this happened to be unilateral, so just one of these pressures was so if that was 100, if one of these pressures, well, we'll make it 120. 120. 190. So if just one of the high thigh pressures was less than 0.9, then instead of aortoiliac, it would just be iliac disease. So this would be the iliac artery that's affected. It couldn't be the aorta, because if it was aorta disease, it would affect this side as well. So it would just be described as iliac disease.
So aortoiliac means aorta and iliac are affected,
It could be,
or it could just be aorta,
could
or
just be
both.
aorta, could just be the iliacs,
but it would be both
or it could be
iliacs.
both. It would be both
Okay.
iliacs, yes. So that's the thing. We don't know exactly where the disease is on a PVR exam. You know, that's why I think PVR exams are a good, PVR SOP exams are a good baseline study. I mean, they're not going to tell us exactly where in the arterial system, you know, that stenosis or disease is, but we can get a general idea of where it is. So for aorta iliac disease, we don't know if it's both iliacs. We don't know if it's just the aorta, or we don't know if it's all three. It could potentially be all three.
Okay, cool. And then just iliac would be like one iliac or the other iliac.
Correct.
Okay.
So that would be a unilateral high thigh pressure of less than 0.9. So if the pressure gradient then is between the high thigh and the low thigh, this would be, hold on 1 second, let me get my chart. Be femoral artery disease. Just want to make sure we're writing this right. Disease. Yeah, SFA disease. Yep. Femoral artery disease. Disease. Pressure gradient. High thigh. Low thigh. It's SFA. Indicates. Let's say we went from 100 down to 65. So our pressure gradient is between high thigh and low thigh. So we know that the disease is between, from this low thigh cuff and up. So what vessel is between, runs between those two cuffs? It's going to be our femoral artery, or SFA. So then in our preliminary report, we describe it as a femoral artery disease of the left lower extremity. The pressure gradient is between low thigh and calf. So we're going 90 down to say, more than that, down to 50. So our drop now is between the low thigh and the calf. So we know the disease is from this cuff and above. So which arteries are within that segment? So this would be described as a femoral popliteal disease. It could be a segment of that distal SFA that's occluded, or it could be a segment of the popliteal artery. We consider that femoral popliteal disease. Pressure gradient is between the calf, ankle. is called infrapopliteal. Yeah. Popliteal. The reason we call it infrapopliteal is we don't know if it's the disease is in, anterior tibial. We don't know if it's posterior tibial, peroneal. We just call it infrapopliteal. Or it could be a combination of all of them. And then the last disease description, this one isn't necessarily based on pressures unless you're doing digital pressures, but I would also have small vessel disease. I use that to describe the arteries of the foot. So if I'm doing, and I have my cuff on the foot, and I'm getting, either, severely stenotic tracing or an occluded waveform from my pulse volume recording of the metatarsal, I would consider that small vessel disease. So small vessel disease can be based on toe pressures, or metatarsal waveforms. So if I'm getting abnormal waveforms in the metatarsal, we can consider that small vessel disease. If the rest of the leg is normal, we've got normal waveforms, normal pressures, and our only issue is with that metatarsal cuff, then that would be considered small vessel disease. And it's based on toe pressures or metatarsal waveforms. I see a disease waveform in just the metatarsal, we can consider that small vessel disease. Any questions about any of this stuff? It's making a little more sense. So for PVR, we described the waveforms as normal, mildly stenotic, severely stenotic, or occlusive. And then we can also, in our preliminary reports, describe the location of the disease as aortoiliac, iliac, femoral artery disease, femoral popliteal, infrapopliteal, or small vessel disease. See, I think I had a report on here. Oh, yeah. So this patient had non-compressible high thighs, and then we saw a large drop from high thigh to low thigh. So that would indicate femoral artery disease or SFA disease. And then another big drop from calf to ankle. So they described it on their report as, I believe, multi-level disease. Is that what they use? Yep. So they call this now multi-level disease. So you can have a patient with two different areas. So it's up to you to describe in your report, as describing as multi-level disease, or you can actually specifically say, like femoral artery as well as, so this would be the infrapopliteal because it was from calf to ankle for the right side. And then they describe the waveforms here. Waveforms obtained that thigh, calf, and ankle were dampened, consistent with moderate to severe disease. So that's another thing I forgot to mention too. You don't have to fully describe. If you're ever like on the borderline, feel free to say moderate to severe or mild to moderate, So if you're ever on the fence when you're describing those waveforms, as, mildly stenotic, or severely stenotic, you can always use kind of like an in-between descriptor. So if you look at the left leg, this one had a drop from the low thigh to the calf. And as well as from the calf to the ankle. So they saw a drop at the posterior tibial. So they mentioned that specifically on the left side, but they say pressure difference between the low thigh and calf level, indicating femoral popliteal disease. When they describe the waveforms, obtained that the left calf and ankle were demonstrated mild disease. So I would say mildly stenotic, my report. Not too bad. Any questions about any of this stuff? No? No? I'm going to post I guess, answer sheet for the quiz. The other students, the DMS girls, found it easier to just like write out an answer sheet, and I'm gonna make I guess an assignment tab that you can either just upload it if you don't want to drop it off the answer sheet. If that's easier for you guys. That's what they decided would probably be easier, just doing like an answer sheet and then uploading it, like emailing it to me, scanning it and emailing it to me, or uploading it to D2L. So you can do either one of those for the quizzes. Anything we need to discuss or talk about before you enjoy your nice long weekend? One day of clinical and then a Memorial Day weekend.
I forgot about that. Makes me not want to go to clinical tomorrow.
Oh, I didn't know that. In here.
Cool. Thanks, Dan. What a thrilling lecture.
You're welcome.
Yeah, thank you, Dan. This was very helpful.
Good. All right, I will see you all. Enjoy your weekend. I'll see you next week.
Cool. Bye, guys.
Bye.
Bye.
Bye.